Welcome
Hey,
to
Jess.
Compliance Deconstructed.
We
I've
are
got my
back.
my fabulous colleagues. I can't believe they're back for more. But yes, they are. And I'm super grateful. So, welcome everyone. We've got a great conversation going today. We're going to talk about what's known in the public sphere as the, oh God, I got to get this out. One Big Beautiful Bill Act. Ooh, I got it out. It's a bit of a mouthful. So we're going to talk about what this means for the healthcare space and what this means for our compliance professionals. Now, I just want to, before we go into the act and talk about what this is, I do want to explain that no comments in this conversation are intended to be political. It really is a discussion of regulatory change and issues that compliance professionals need to be aware of. We all work in this thing that we call a healthcare space, and regulatory issues affect that space. We've got to talk about them. But please, in the way that we discuss these particular proposed changes, understand we're not being political. We genuinely have some questions about the proposed act and how this affects us in the work that we do. All right, so please take the conversation in that vein. This is a discussion really for exploration and educational purposes only. All right, so with that caveat said, what is this thing that we call the One Big Beautiful Bill Act, and why are we talking about it? So if I, summarize, this is a proposal that is intended to improve healthcare billing transparency and coordination for patients. It's about simplifying billing and how we pay for healthcare. But what are the details? Does this proposal, and it is just a proposal at the moment, does it actually achieve, does it look like it's going to achieve this goal about simplifying billing? And that's what we'd really like to examine today as we go through it. Elvan's shaking her head no, right from the beginning.
It's all
right
about the
out
money
gate.
again. Talk to me about money. It's all about the money. It's all about the Benjamins. Okay, sorry.
Well, but that's not a surprise, right? The
No.
administration is saying, hey, we're going to give more emphasis to fraud. We're going to really look at this. And so it's not necessarily a surprise that we're seeing the One Big Beautiful Bill Act. And if that does tie to money and fraud, or is it really just about genuinely simplifying the process for patients and for the public? So, Lorie, are you able to kick off and tell us, what are some of the key aspects of the act and why do some people think they're problematic?
So the big thing about the One Big Beautiful Bill is it is intended to be part of the budget reconciliation that they do on an annual basis. However, this new administration has decided to make clawing back social programs a part of their focus. So one of the big things that they're looking to do is shift redetermination of eligible Medicaid members from annually to every 6 months. That puts a huge amount of administrative burden on the state Medicaid agencies, CHIP agencies, ACA agencies, as well as the individual MCOs or managed Medicaid plans or whatever they call them in your state to do that burden, because it's a combination of working with the county offices that typically enroll members into Medicaid, and then the plans work with the state regulators to do that redetermination to ensure members continue to be eligible. So that for me is the biggest red flag. The other thing that it aims to do is, starting in, I believe, the 2027 year, is it cuts those tax credits that go for the ACA marketplace and the ACA. So that's ACA is intended to be a safety net for those states that have the Medicaid expansion available. It
Mhm.
also will
And
cause
that's the safety net. Sorry,
Mhm.
that's supposed
Yeah,
to be a safety net. So that's
yes.
a big deal.
Yes, and it's also gonna increase the prices, so if you take away ACA access, it also makes it less affordable. Another thing that it does is it takes away auto re-enrollment. It requires that 6-month redetermination that I talked about. So that is also a large issue. So again, it puts more administrative burden on members, those county offices, those state regulators, and the individual health plans that service members. So I think for me, that those are kind of at the very high level. There's a lot in this bill, but at the high level, those are the things that I think about. And it makes me think about the vulnerable populations that are going to be impacted. While it puts in those work requirements that, let's be honest, work requirements are happening already in Medicaid. They just aren't written out. I think if you follow Kaiser Family Foundation or kff.org, I think they estimated somewhere in the neighborhood of 90 plus folks that are on Medicaid and ACA that are working already. And the folks that aren't working typically have conditions, physical, mental, developmental, that they cannot work. So it's doing what it's intended to do, but it does make those vulnerable populations just a little more vulnerable. So I
So
think,
let's roll back. Sorry, Lorie.
yeah,
Can I
Mhm.
is it okay to interrupt for just a
yeah, I was
moment?
actually going to transition to you, so it all works out.
Okay, I'm sorry. I
No,
feel like
no, it's all
so
good.
rude.
No,
Um,
no.
so I just for our listeners,
Look
I
at this
just want
nice host
to
that we have. She feels rude when she, interrupts, and I'm like, "Excuse me, I gave a warning." Shh. That's how I feel.
Oh no, I don't like to interrupt people, but I was just going to add to what you said. I just wanted to back up for a
Mhm,
moment and say, for those of you who are listening, some of the proposal includes things like work requirements
mhm,
for those on Medicaid, talks about cutting back some of the student
mhm,
support. So those who go to medical school or go to get clinical training, cutting back some of those loans. That's the graduate medical education program. And there are implications as well around gender affirming care being banned in Medicaid. So it was just about adding, Lorie, to your list. So when we're looking at what the act is proposing, we have some real concerns about the effect on the populations that we serve. So when you think that there's going to be, no automatic re-enrollment, like that's really difficult. There are implications. Not everyone can go, and we'll do a deeper dive, but not everyone can go back and re-enroll all of the time. And we'll talk about why that is. But in having a redetermination where your eligibility is assessed much more frequently, like, is that the best use of resources, especially with the population who, we know they have complex needs and that they're going to need the services. We're not talking about a population in the main, anyone can come onto Medicaid. Like, that's not what's going on here. We're talking about a really sick, high need population and how these, proposals are going to affect them. And what's the implication, again, of these tax credits and the implications of not supporting people to get into the medical profession and the implications of not providing gender affirming care, because it's not just about that care, it's about associated parts of care. And we'll do a deeper dive on that in just a minute. And where I think Lorie was going was when we were talking amongst ourselves, getting ready for this podcast, one of the things we were wondering, and we were wondering a lot of things, truth be told, but one of the things that kind of concerned us was what's the impact on healthcare disparities? Is it possible, and some might argue one way or the other, but we asked the question, is it possible that this particular proposal, one of its unintended consequences is deepening healthcare disparities. And that was something I think we wanted to start talking about. I would argue, yes, yes, it does. And it does it in so many ways. But before I go there, I mean, Lorie, Elvan, do you have any particular thoughts?
I mean, for me, this is a hard subject because when we do, and I just wanted to quickly touch on determination is based on few factors. Yes, it can change on black and white on the paper from 6 months to 6 months. Correct. Yes, it can. But the reasons that got that person to be eligible to begin with will not be gone based on the new factors on that paper. Meaning they will be re-eligible, quite likely, possibly. I would love to see the statistics on that one. 6 months they're eligible, the next 6 months they're determined they're not eligible, maybe another 6 months they're doing fine, and then comes the time because they're just on that cusp, right? But they're looking at black and whites. They're not fine. Now they're sicker. Now the system is burdened by a sicker person who was told you don't qualify, go take care of yourself, who didn't due to the cost, and now comes back into the system of Medicaid sicker with higher needs. That's going to cost the system more. So, what did we do?
And I think, and I agree with you. I'd even go a bit further than that, right? I mean, so we mentioned briefly in the intro, I mean, these are people who may or may not be able to communicate. They may have complex needs. They may have physical or intellectual disabilities
Mm-hmm.
that may make it very complicated for them to get through the process. What does that mean for access to care? What if they can't get through the process? Does that mean they fall outside? They don't get the health care that they need? Right? And that worries me because that means that you might have the potential to have a whole lot of people who find it difficult to engage with the healthcare system anyway. And I'm a caregiver. I don't know about the two of you, but I care for an elderly aunt. And I have to tell you that it feels like barriers. She can't get through. I mean, she's not on Medicaid, but she is on Medicare, right? And the more maybe, in the government or as health plans, we don't feel that they're barriers. But actually, if you're the recipient on the other end, then having to go through these processes sometimes feels like hoops. And they're not really designed for people who are sick and vulnerable, right? And that really worries me. I see the potential for the very population we're trying to serve and address being shut out by some of these changes, for the lack of auto enrollment, for the whole redetermination process. I'm worried. I don't know for sure that this will be the impact, but I'm a little concerned. And I also think that it could result in indirect discrimination of populations that typically find it difficult to engage with healthcare anyway,
You just took it out of
right?
my mouth.
Yes,
Mm-hmm.
and I think about, well, it could be populations of people from cultural backgrounds who find it difficult. It could be things like people who certain communities,
Mm-hmm.
LGBTQ, and also, trans people who generally aren't engaging with the healthcare system. They're
Mm-hmm.
suspicious, and rightfully so. But this makes it even more difficult. And, you might have people who stay away from the healthcare system now because it's even harder. They have to go through more. Or what about people who live in very rural areas or where there are healthcare deserts? And it's difficult to get them engaged in the healthcare system anyway. Well, what does that do to those particular groups of people?
I think that's a very
I'm
good
worried.
unintended discrimination is the perfect verbiage that you put out there. Agreed. The best example that comes to my mind, and this is not the place nor the time to talk about it, but it makes me think about certain populations. being stuck in the criminal justice system because they do not know how to interact with law and the parts that make up law and order. And it just becomes a cycle, right? It's just, anyways.
The one thing
Lorie.
I wanna remind you, though, is that when you're incarcerated, typically Medicaid under a managed care plan is typically suspended. And when you're released, you can reapply, but you have to go back through the application. Not in every
I didn't
state.
know that.
So please, like, consult
Because
your
the,
state
yeah.
agreement on rules for incarcerated members. So typically when a member's incarcerated, they're typically covered under a like a fee for service plan or something through the state because they're incarcerated, at the state or at the federal level, they're getting some sort of health care. So again, just consult your state agreement on whatever the rules are about incarceration, but still a very vulnerable population that is prone to illness and things like that. So just wanted to point that out.
Yeah. No, this is why we listen and do the podcast. Always interesting things coming up in the conversation. So I definitely, and I think we agree, we're quite concerned that the proposals here might inadvertently shut out certain groups of people just because it feels like it could potentially be putting additional hurdles in place for certain groups of people to access healthcare. And that's problematic. As compliance officers, we've really got to think about that, right? One of the things that we're regulated against in our organizations is access to care. And this isn't quite within our control. So we've got to think about and plan for, how we might be able to mitigate potential impacts. Because again, we don't know for sure this is going to happen, but we fear that this could be an unintended impact. But moving on from that just a little bit, I do want to talk about, the potential impacts on the healthcare workforce and what some of the provisions of this proposal might do. And so, the proposal talks about caps on federal loans for medical education and also ending loan forgiveness programs for public service. And that worries me a little bit because I want, the impact of this. So, first of all, some might argue and think, oh, well, who cares? Because doctors make a lot of money. Well, actually, doctors don't always make a lot of money. And we're not talking just about doctors. We're talking about a range of different clinicians and professions. They don't all make, hundreds of thousands of dollars and own a big mansion. That's really probably not the normal case, right? That's far and few between. And the cost of getting medical education is expensive. And it doesn't matter what profession you are. Yes, medical school might be the most expensive. I get that. But actually, training to be a clinician isn't cheap, period. And you don't always make a lot of money at it. You do it, yeah, you're probably going to have, pay your bills, but there's some values that you believe in. So what does it mean if somebody, is saying, well, we're not going to give you loans, or we're going to cap it. We're going to make it a little bit harder, that much harder for you to get the qualifications that you need. To me, that worries me because and I've seen it happen before. So you guys, I worked in England for the longest time. And what tends to happen is people make a choice. And we've seen this with teaching as well. We've seen this. People can choose not to go into certain careers. So, is there a risk by removing the support? Are folks going to be saying, well, this medical career isn't really a good choice? We're looking at, the debt that we're going to accrue versus what we're going to be able to pay. Is this the right career for us? And we might find that clinicians are backing off. This is not such an attractive field to be working in. And if they're doing that, what does that mean then for those of us who are the recipients of healthcare, which is just about everybody? I don't know. I fear, I think about, and it might not be immediate. It might not be today. Although that said, we already have staff shortages. Thank you so much, COVID. Isn't that wonderful? So if people are being turned off from the profession, what does that mean in terms of our ability to access the care that we need? We're already short many, many different specialists. Try and get a rheumatology specialist. There's really, that's
Yeah.
rough.
I think part of this is that for the audience to understand is that becoming a clinician, yes, it's a passion, but ultimately it's an occupation. Nobody wants to be hungry just for their passion. There's just a few artists out there struggling, but we all want to eat ultimately. And when you look at and then there are the deterring factors, right? The positive is that I want to do this, I want to help people, I love science, just quite a few factors that makes you want to go into medicine, allied medicine, all of that. But then there are the deterring factors. It's a well-known fact that the suicide rates are extremely high among physicians. The length of schooling is very, very high. It's not a 4-year degree for a lot of them. We're looking at a 15-year engagement, during which you really cannot hold even a part time job due to the load that you're going to bear, which means you're going to take more loans or depend on another financial resource should you have one, which I'm sure you will deplete that one. Then you come out knowing that no, you're not going to get that job that makes you 120, 150 right off the bat. And who cares if you're making 120, 150 if you have $1 million loan at the government's set rate? That can
And
never be
I
excused.
And I totally get it. I think a lot of our listeners might, find it difficult to sympathize with some of those clinicians who are maybe earning a little bit more. But I'd put it to you guys this way, and Lorie and Elvan, tell me what you think. What we haven't talked about are some of our lower wage earners, right? And how this bill might impact them. So what it's doing is it's suggesting it's possible that a result of this act, many people lose their coverage, right? So, what does that mean for lower wage earners generally? But also, what does it mean for lower wage earners in the healthcare sector? If they're losing their coverage or they're at risk of losing their coverage, how are they going to be able to continue working? Think about maybe some of our cleaners, or how about some of our home health aides, our direct care workers, our behavioral health techs, and our rural and part time clinicians. If this bill goes through or this act goes through, there's a chance that we get a lot of people losing their coverage as a result. That's something we haven't quite talked about, but we touched on it as part of the ACA intended. ACA is a safety net, right? If the ACA is changed or removed and people lose their coverage, and they're low wage earners, like how are they going to be able to help us maintain the health system that we've already got in place? I think that worries me more. I'm worried that, clinicians themselves are going to be looking at the sector and just going, no, like it's just not worth it. We don't get the support that we need, so it's not worth it. And then I look at, you know, lower paid workers, and I'm thinking, I mean, it's a little bit off topic. It's a little bit off topic. Yeah, they're non-regulated, it's a little bit off topic, but if we're talking about payment and compensation and burnout and what that means, I start to think, hold up, wait a minute. The biggest risk is for those staff who aren't earning as much, who aren't as qualified, and where do they go? What does that mean for our healthcare space? Lorie, are you trying to add something?
No, I'm just listening in, but I think that this is the time to get ready. This is now when compliance folks, why does this bill matter? I think as compliance folks, what we need to do is we need to start talking to the teams that are going to be impacted most by this change, starting with our friends in enrollment, where eligibility will be impacted. This isn't all bad. There are some positive things that I think are in here where it's going to maintain that $35 copay for Medicare. Medicaid typically has low copays, so the $35 is not really advantageous for us, but I think that we need to also make sure that our configuration friends, our claims folks, they're ready. We also need to start talking to our IT teams, because one of the provisions in here would require a state to state database at the state level, but quite possibly we would have to be able to plug into that at the MCO level, at the managed care plan level, that when this database goes live, if Lorie Davis enrolls in Medicaid, they check to make sure that Lorie Davis isn't enrolled in any other Medicaid plan. So I think that is a provision that we need to start having these conversations. Maybe right now we're at the 25. Oh, sorry, my hand got out of range.
I'm
At
like,
the 25.
whoa.
Yeah, I'm way up
She
here where
lost
you
her
can't
hand,
see.
folks.
At the 25,000-foot view, where we're just starting to broach the conversation, and we need to prepare to act, but we need to make sure folks are aware. I think for me, it's all the things in here when I look at it that won't take effect immediately versus those things we need to start thinking about. So those good faith waiver payments that might disappear, doing auditing, how is our eligibility looking now? How is redetermination working now? And understanding when this change goes from 12 months to 6 months, are we ready? What do we need to do? Do we need to staff up? Do we need to change how we staff? What sort of things? I
Examining
think.
what your staff
Mhm,
looks like at the moment. What are the specialties?
Mm-hmm.
And
mhm.
really thinking hard about that, and whether you have gaps.
Yeah,
Even now, thinking about what that's going to look like in the future. That's right. Yeah.
yeah, yeah. As well as, I think another thing that's in here is out of state pediatric provider right now. And Jess, I know you and I had conversations over the years about those pediatric members that want to leave their current state and want to go to another state where a specialist is available or a specialty is better served. Right now, that's not always automatically approved. So we need to look at our policies and procedures to see what's in there and what changes the state might have to make that would impact us again at the plan level. And make sure that you look at that, and it again, it doesn't take effect right away, but it will be coming. So we need to start having those conversations with our stakeholders, with our business owners across the organization about what's in here, and put aside any hype or hoopla, and really prepare, and take it one day at a time. Let them ask their questions, and if you don't have the questions, start crafting those questions that when you meet with the regulator, who probably also has some questions, and making sure that they know, hey, we're following this, we're prepared, but there's some gaps in our knowledge that we need you to help fill.
And there you have it from Dr. Lorie Davis, our group
on,
therapist. No,
on
she's
today's
shaking her head.
episode
No,
of
no, Jess,
Compliance
don't say that.
Deconstructed.
That's the second time I've noticed, in our previous episode as well. Elvan and I are going through the implications like, oh my goodness, what's this mean? And you're like, no, wait a minute. Let's calm
We're like,
down. Let's take a step back. But Lori's right. Lori's right.
yeah,
And
absolutely.
Lori's right to do that. And to be fair, Elvan and I would do the same thing. If we weren't on this
Yeah.
podcast and we
Well,
were really in front of people, we would be saying the same thing. All
and don't
right.
feel bad.
Let's
Lorie is hyperventilating. There's a part of Lorie that is hyperventilating because she's hearing some of her business owners in her head
Oh,
going, Lorie, I have no idea how I'm going to do this. What do you mean I have to do this by December 2025? Oh my God. Oh my, like, I'm hyperventilating with
hmm
you, but
hmm
I'm trying to be very calm and measured and collected so that we can get through this, because
because
that's
it's
the
gonna
only way
get
you get
done,
through it.
right? It's gonna, yeah,
And
one step at a time. It's gonna get done.
we don't know if it's gonna pass.
Hmm
There's a lot of uncertainty about where it lives in the Senate right now. It's gonna have to go back to the House. Several of the legislators that voted for this in the House have since said, hey, I didn't realize that when I voted for this, there was X, Y, and Z provision included in this.
Oh,
So when it goes back, I think there is some more changes that will need to occur. And because this is reconciliation, that's what typically happens. But again, I want to prepare people because, what is it that they say? If you're not prepared and you're not forewarned, you're caught off guard or you're behind the curve or there's a phrase that's escaping me, but I think we just need to get it together.
No, and I think there's a space to say, look, you've got to incorporate some of this into your strategic planning. Keep an eye on the regulatory space, but there might need to be a conversation, and your strategic plan for the next couple of years may need to be adapted. But don't ignore it. Definitely, keep your eye on it. I think, ladies, where I'm struggling is in understanding if the proposals are intended to streamline billing for people like us, for patients. I guess I'm just I don't know. I'm having a really hard time reconciling the goal with what I'm seeing. And maybe I'm looking at the proposals too narrowly. Like I get it. But I'm struggling to make that connection. And I feel like I'm missing something. And maybe I am. I don't know, but what are your thoughts? Your initial
Here are my
impressions just
dollar
as
bills.
people.
Where I next time we're
Oh,
shooting this,
she's
I'm coming here
all
with my
about the
dollar
money,
bills.
folks.
But I mean, I think the good intention, I have to believe, I have to think the good intention is to cut unnecessary cost, streamline processes, make things fair is not the right word, but make things more fair across the board. But then you see all the other details and you start thinking about the implications. Then you say, this isn't fair. And how about this person? This doesn't look right. It's not going to cut the cost. It's going to add cost at the end. Then you realize, much like all of these bills, do you realize intention was good, but the execution is probably going to kill some of that good intention. It's just a feeling.
I can see that. I guess I just feel as a person like there's a gap between the intention and
Yeah.
what might actually happen. And I don't
Mhm.
know if I'm reading it wrong or I'm kind of colored by my
Mm,
own particular biases. Like I'm a little worried about that sometimes. But Lori, you're shaking your head. Did you
Yeah,
want to add anything?
I do think that the intent here, we know that this administration, one of their mantras has been to shift things to the states, right? And I think in some of the wording and what they're trying to do, I do think they are trying to shift that ownership or that onus onto the states, but they haven't accounted for the financial burden of what they're trying to do in that shift. I also think that we've talked about this previously in fraud, waste, and abuse, and the perception that enrollees or Medicaid beneficiaries or CHIP beneficiaries or ACA, whatever the beneficiaries are, they are somehow defrauding the system. And so some of these rules, I think, are trying to ferret that out, putting
Yes.
an implication
mhm.
that the state regulatory agencies or the marketplace folks aren't doing their duty. And I don't know that that's true. And, I think we talked about that during the fraud, waste, and abuse discussion. So I think it's really important that we remember what the administration is trying to do
Mhm.
and the fact that this is in some way trying to shift more on. But I think for me the short-sightedness in this is the fact that ACA is intended to be the stopgap and they're gutting even that. So it very likely could leave many Americans without any healthcare coverage because they can't afford ACA, they make too much to be on one of the
For
government
Medicaid.
supported, they're
Yeah.
not old enough to get on Medicare, they don't have children or their children don't qualify for CHIP. So it just leaves folks, and I've heard some of the representatives and senators say, "Oh, well, this is going to take away your government subsidized insurance and you're going to replace it with workplace insurance. And I think that's disingenuous, because think about how many workers are in the workforce today that are on Medicaid, Medicare, ACA, because their employer doesn't offer insurance or
Yes.
affordable insurance. So I think there has to be some reconciliation in terms of what employers are truly offering in terms of health care, and what's available and what's affordable, and how we make that Lorie Davis Venn diagram in her head of how those all overlap.
Mhm.
And I think that's what is contributing to the
Mhm.
disconnect that I'm feeling. I wasn't able to articulate it in
Yeah.
quite the way that you did. You really did a great job of, explaining what that kind of
Mhm.
what I feel like Elvan and I are experiencing, and clearly
Mhm.
you're experiencing that as well. So what I'd say is we're looking, to finish off the podcast, a couple of really big takeaways for everyone. So really thinking about remembering to stay up to speed with what's happening in the regulatory space. Keep checking. Make sure that you're communicating with the organization, even if there aren't any changes yet, because this is a proposal. You need to be aware, and your organization needs to be aware that things might be changing, and you need to have a plan, right? So that's number one. Number two, really, I think it's important what we've learned from this process and from, getting ready for this podcast, is the importance of critically looking at some of these proposals, as you would anything, as you would a proposed rule, a final rule, any regulatory change, but really making sure that you're looking critically between the intention and what's really happening on the ground and how that impacts your organization, and thinking about how you might be able to get in front of some of those challenges. To me, those are really the important takeaways. It's not so much at the moment, the content, we can all have an opinion on the content and the impact, right? And those opinions may vary. But the point is making sure you understand what the changes really are and how you need to respond. That to me are the biggest takeaways. Is there anything, Lorie or Elvan, that you would add or disagree with?
And time will
I
tell,
agree with
right?
you.
Much like with everything. Once things pass, time will tell. And we'll be talking about that, what time told us.
Won't we just? All right, everybody. Thank you for sticking with us and listening into our conversation on the One Big Beautiful Bill Act. Hopefully, you got a sense of what some of the challenges are and how that might impact your organization and your particular role in the scheme of things, how you can facilitate
Mhm.
this conversation and raise some awareness, right? Thank you all. We'll see you next time. Take
Thank you.
care.
Thanks,
Alban,
everyone.
Bye
Lorie.
bye.
Bye-bye.